Our next speaker is Dr. Chris Frank. He's a graduate, it says a number of years ago. I'm not sure why that's relevant, but those are my notes. So, from the University of Western Ontario, yeah, because you won that over prize instead of the under prize. He's worked at St. Mary's of the Lakes since completing additional training in the care of elderly at Queen's. He's a clinical leader of specialized geriatrics at Providence Care, and his main clinical roles are in geriatric rehab and in the palliative care unit. In living his dream, he apparently hopes to mountain bike until he's well into his 90s. But without further ado, he's here to speak to us about our second area of research to consider, which is aging.
Thanks very much. It was a delicious meal, and I did feel funny eating that moose just as Shauna was talking about all those things. And it will affect my mountain biking career, I'm sure. So I'm going to talk about aging, and subtitle, Trying to Stay Ahead of the Tsunami. And I think the aging tsunami is a term that's sometimes used, and I actually had an English major do a podcast for me for the Canadian Geriatric Society because she's got a great interest in the use of the term aging tsunami and how it actually is a little bit of a derogatory term. So I put it in there deliberately because you hear this term aging tsunami all the time, and yet it is very clear that there are a heck of a lot of older people around, and my kind of clinical experience is I used this line in the room earlier in the year that 90 is the new 80. So there are a lot of people over the age of 90 now. And I used to tell my residents that if you're never sure how old somebody is on our ward, just say 84. But now I'm sort of saying, if you don't know how old somebody is, just say 87, because that average age is going up and up. And this is a sort of a portent of things to come. This is Madame Jeanne Calment, who is the person who's lived the oldest with a well-validated birth date ever, as opposed to the ladies who live to be 150 in the Balkans, living on yogurt. This lady actually was, I think, 122 when she died, so she has reached the maximum lifespan of a human. The biogerontologist, there are some that say that the person who will live to be 200 is alive today, and there's actually one slightly crazy guy that says the person that will live to be 1,000 has been born today. So clearly there's a bit of an imperative to improve our understanding of aging, but also to improve our understanding of the care of older people. So where are we now in the world of geriatric research? I think there's obviously a lot of people doing research in geriatric care, but I think that at the moment we're still extrapolating or taking research done on a younger population and just applying it. And I can assure you that applying research findings on a 62-year-old doesn't really apply to a 92-year-old. And I think, we see that clinically in that when I work with someone who's in their mid-60s, it's a very different experience from a physiological point of view, from an interaction communication point of view, and from an outcome point of view compared to when I'm working with folks in the much more higher age range. So I think we really need to pay attention to the amount of research that's done in aging, because we really are sort of on that aspect of the wave moving forward of people getting older. I'm going to move this drink here. So why worry about aging? I wondered, maybe I'll throw this question out to folks in the audience. What would you think would be areas of important research in aging other than the likelihood of living to be 100 as a smoker? Any thoughts about what you would see as priorities? Mobility. So mobility, given joint issues, given increasing prevalence of neurological issues, clearly an important factor. Any other focuses? Hearing. Yep. So those things that really don't seem to get very much research and yet are things that have such a huge impact on quality of life and function.
Alert mind.
Yep. So cognition in general. So alertness, ways of preventing dementia, those types of areas are all wide open fields. So what are some of the facts? I saw this in that most scientific of journals, the Week Standard, recently, that commented that by 2030, almost 25% of people in southeastern Ontario or in our local counties will be over the age of 65. I looked up the Stats Canada. In 2060, it will be, I think, 25% in the country as a whole, but we actually have a slightly older population in southeastern Ontario, in case you hadn't noticed. One thing that this means is that almost a quarter of drivers will be over the age of 65. So I think that that does have a big impact. Not that because you're older means that you have more issues with driving, but it definitely means you have more medical conditions that could cause troubles with your driving. As most of my elderly drivers say, it's like, well, I just about got run over by a 25-year-old driving like a maniac. That 25-year-old's partly doing it by choice as opposed to dealing with a neurological illness or a dementia. Long-term care, one area, I'm not exactly the most prolific of researchers, but one area of research I did look at was human health resources in long-term care. And as the population ages, obviously long-term care needs will grow. And we already have a group of long-term care medical directors who are themselves over the age of 55, and many of whom are sort of saying, I'm out of here soon. So there's an impending crisis in physician and probably other disciplines, human health resources in long-term care, at a time when there's going to be a lot more people needing those beds. Hospital costs and the costs of home care, the community care access service, are all obviously in the media pretty much every day. So they're all things that are increasingly causing me to occasionally lose sleep at night, and I'm sure they cause the Minister of Health to lose sleep as well. So it's nice and easy in Canada to sort of identify the priorities because aging is an important enough area, hint, hint, that the Canadian Institute of Health Research has an Institute of Aging, and they've come up with what they've set as their funding priorities. So one of them is healthy and successful aging, and I still get emails from a company that I foolishly put my name down on the list for, which is more about what they call anti-aging. And anti-aging is that sort of movement which essentially says that aging is a disease and here's your strategies to avoid getting the disease. Whereas healthy and successful aging is the more realistic picture of what are the strategies, like Dr. Johnson was mentioning with obesity and with blood pressure in pregnancy, that will help you age better. And obviously we all know the answer to this, but what are the specific strategies that can help people to age successfully, etc. Their second priority is the biology of aging. What are the things that actually happen in our bodies to contribute to aging and to contribute to the risk of age-related diseases? So that's an area of some interest to me, and if you are interested in this field, you can look up aging on TED Talks, and one of the most famous biogerontologists talks about how the person that's 1,000 years old is alive today. Cognitive impairment in aging is one of the risk areas identified by our audience. Aging and the maintenance of functional autonomy, which is kind of what we try to do in our work, which is to help people recover or help people prevent loss of function and loss of autonomy. And equally important, what are the systems of care and the health policy issues that will help people age successfully and help them deal with some of the challenges of aging? So the nice thing is we have our priorities kind of outlined already by a group that's taken into account input from researchers, from policymakers, and from folks like you. What do I see as being big priorities? I'm involved in a research project right now looking at how physicians should approach people with mild dementia who still have a driver's license. But driving safety as it relates to other illnesses such as heart failure, which is incredibly common, such as very banal things like arthritis, which obviously cause huge functional problems, but we don't always associate with driving limitation. What are cancer treatments that are appropriate as people age? What's successful given the changes of the aging body on the response to chemotherapy? How should we be treating 95-year-olds? So, for example, we give Coumadin to prevent strokes to people over the age of 65 if they have atrial fibrillation, the irregular heartbeat. But I've recently looked at the literature, and there is no data on people in their 90s. So I'm giving people a fairly toxic drug, which is listed in the top 5 of dangerous drugs, and yet I have no guidance as to when we should be stopping it because the risk starts to outweigh the benefit. So what are treatments in the elderly? One of my colleagues is doing research on what are the outcomes both from the patient perspective and from a living situation if you're 92 and you end up in the intensive care unit. And I can tell you the intensive care unit is full of people in their 80s and 90s. It's a huge growth area of care. So this is the outcomes of aggressive interventions in frail older people, and really importantly, what are the models, particularly in family medicine, that are helpful? And Marg Alden's got a real interest and expertise in this. An area that receives very little focus in research, and I think Kingston's very well placed to do it, is in long-term care. So several years ago, Providence Manor became a teaching nursing home, and all of the family medicine residents have to do a rotation in long-term care, which is great in making it seem like an actually attractive place to work, as opposed to, I don't want to go work there, it's just a depressing, horrible place. But it's an area that the research potential has never really been explored. So I would like to propose certainly long-term care as being an excellent laboratory where you've got a sort of a captive population, to use that term, but I think where there's a lot of unanswered questions. What treatment should we be stopping as people go into long-term care because they're not helpful? What are preventative strategies that can help to decrease illness and decrease pain, etc.? What are the models of care that work? A friend of mine did research in Halifax that found that of the people who were transferred from the nursing home to the acute care hospital in the middle of the night, 70% of those people had a directive that said, I don't want to go to acute care. But because they couldn't get a hold of the physician in the middle of the night, they were often shipped. So there's lots of examples of practical research that can have an impact on individual lives. And educational research, including how do we recruit people to long-term care, which is not exactly the sexiest area of medicine. What's going on locally? There's a very strong neurosciences program at Queen's looking at things like dementia and neurological illness. There's the Human Mobility Center at KGH looking at relevant things like gait and joint replacements, things that are all relevant as we get older. The Center for Studies in Primary Care at Queen's looks at family medicine research. There's the Developing Institute for Military and Veterans Health, and sadly many of our veterans are actually getting very, very old, but there's always new veterans to come along, unfortunately, as well. The Cancer Research Institute and at Providence Care, the Center for Studies in Aging and Health are all areas that I think where there's a work going on that has a real focus in the elderly. The picture at the bottom is the fellow doing research in end-of-life communication as well as in what happens to old people in the intensive care unit. So, to my worthy opponents, I think just to summarize, we are all in this room getting older. I think we all see that in the mirror every day. There's clearly going to be, without fairly significant changes in the aging process and our care processes, an increased burden of care and increased costs as the population ages. Our goal really needs to be looking at trying to, what we call compression of morbidity. Morbidity just means bad health and bad function and not a great life. At the moment, we're doing a great job of making people live longer, but we're not shortening that time that they're functionally dependent. At the moment, people have often a long period of challenging health issues and challenging functional issues. While living longer, it may not be the best of times. Clearly, caring for aging relatives has an impact on young families, so it ties into maternal and fetal health, and it has an impact on mental health, so we kind of cross a number of the different fields. And the care we provide for older people should be interdisciplinary, and I think there's lots of scope for interdisciplinary research in aging, no matter what field is chosen. So thank you very much.